Welcome back, everyone, to another deep dive into the world of microbes. And today we're tackling enteric fever.
Yes.
So obviously we're focusing this deep dive on the needs of medical microbiologists.
Right.
So thinking about all the things that you need to know to keep up to date on the latest diagnostics and treatment recommendations.
Yeah.
And, of course, all within the context of antimicrobial stewardship.
Yes, very important.
For this deep dive, we're really going to be using the World Health Organization's AWARE guidelines on antibiotic use as our kind of main compass. And specifically, we're looking at Chapter 6, which covers enteric fever. And, this is really considered the gold standard for guiding these treatment decisions, especially in a world where we're grappling with increasing antibiotic resistance.
It's a big problem,
So before we jump into all the nuances of diagnostics and treatment, I thought it'd be helpful to kind of get us all on the same page about the fundamentals of enteric fever. So I guess maybe we can start with a really precise definition of what exactly is enteric fever.
Right, let's do it. So enteric fever, it's not your everyday upset stomach or anything like that. It's a serious systemic illness. And it's characterized by fever and abdominal pain. And the bacteria that cause this infection are Salmonella, enterica serotypes, Typhi and Paratyphi.
Okay, so Salmonella, Typhi, and Paratyphi.
Yes.
Now that's different from non-typhoidal Salmonella.
It is. That's an important distinction to make. Non-typhoidal Salmonella, they might cause gastroenteritis, but they don't lead to that same systemic spread that we see with enteric fever.
Got it. Okay. So I guess it makes sense then that, public health measures, things like, safe water, sanitation, good hygiene practices, those are all essential for preventing the spread of this disease. Yeah. It's kind of amazing to think about how these really simple public health interventions can have such a profound impact.
I know, right?
On disease transmission. Now I'm curious about the clinical presentation. We know it can mimic a bunch of other febrile illnesses, which can make diagnoses really challenging.
That's right.
What are some of the red flags that should make us think, okay, maybe this is enteric fever?
You're absolutely right. The nonspecific symptoms is one of the biggest challenges. So typically you'll see patients coming in with a fever that lasts for a while. It's often over 38 degrees Celsius for more than 3 days. And they might complain of headaches, loss of appetite, and nausea. You'll also see gastrointestinal symptoms like abdominal pain and constipation. But those aren't always there.
So it's not a guarantee.
Not at all.
You're going to see the abdominal pain or the constipation?
Not necessarily.
Okay. Interesting. Now, diarrhea. I always thought that was a hallmark symptom of enteric fever.
Well, that's interesting you say that diarrhea is actually less common, but we do see it more frequently in children and people who have compromised immune systems, like people living with HIV.
Okay, so it's kind of the opposite of what I thought. I thought it was always diarrhea, but it's actually more rare. It's really fascinating how, the host factors can influence how the infection plays out.
It really does, yeah.
Yeah.
The host is so important.
Now, speaking of how the infection plays out.
Yeah.
Let's talk about complications. What should we be really on the lookout for?
Okay, so one of the big ones is intestinal complications. And probably the most feared one is intestinal perforation.
That's really serious.
It is. It can be life-threatening, and it requires immediate surgery. So you have to be really vigilant for signs like sudden, severe abdominal pain and tenderness guarding rigidity.
If you see those, you got to act fast.
You got it. Early recognition is critical, and prompt intervention is absolutely essential.
Okay, so that's one complication. Intestinal perforation. What are some other ones?
Another potential complication is encephalopathy.
Okay.
And that can manifest with things like altered mental status, seizures, even coma.
Wow.
It really highlights how enteric fever can impact multiple organ systems, not just the gut.
That's a scary thought.
It is. It's not just a simple GI bug.
No, it's definitely not. So even in those cases where it seems pretty straightforward, you still have to be really careful.
You do. You always have to have that high index of suspicion, especially in areas where enteric fever is common.
Okay, now let's shift gears a little bit and talk about diagnostics.
Oh.
Because, we know.
Yeah.
Getting a quick and accurate diagnosis is absolutely crucial for effective treatment.
Yeah.
So what are our go-to laboratory tests?
Yeah.
We're thinking, okay, this could be enteric fever.
The first thing you want to do is get blood cultures. And get those as soon as possible, ideally before you start any antibiotics. And it's important to remember timing is key here. Early in the illness, that's when those blood cultures are most likely to be positive.
Okay, early is key.
Early is key.
Now, I was taught that bone marrow culture is considered the gold standard. Is that still true?
Yes, bone marrow culture is still considered the most sensitive diagnostic method, but it's not always practical. It's an invasive procedure and requires specific expertise, and it might not be readily available in all settings.
So you might not be able to get it done.
Yeah.
Even though, in theory, it's the best.
Yeah.
Okay, so blood cultures are usually our best bet. What about stool cultures? Are those useful for diagnosing enteric fever?
Stool cultures can be useful, but they have limitations early on in the disease. They become more positive as the illness progresses. But ideally, by then, we want to have already started treatment.
You want to be out of the game.
You do. You don't want to be waiting around for those stool cultures to come back positive.
Got it. Okay. Now, there's also that serological test called the Whittle test that I remember learning about. What are your thoughts on that in today's practice?
Oh, the Whittle test, it's kind of fallen out of favor. And that's because it's not very reliable. It detects antibodies against Salmonella, but a positive test doesn't necessarily mean the person has an active infection.
So it could be from a past infection?
Exactly. It could be from past infection or vaccination, or even cross-reactivity with other bacteria.
So it's not the best tool to use?
It's really not. It's not the one we reach for first.
No. Okay, so we've talked about the key microbiology tests. Are there any other laboratory tests that can help us figure out, how severe the infection is or how to manage it?
Well, so while they're not always necessary for diagnosis, routine hematological and biochemical tests can be really valuable, especially in severe cases or if you suspect complications.
So what kind of tests are we talking about?
Well, a complete blood count, for example, can tell you if the patient has anemia, which is pretty common in enteric fever. And it can also reveal leukopenia or leukocytosis, which can be an indicator of how severe the infection is.
Well, that's useful.
It is. You can also check liver function tests, and you might see elevated transaminases, which suggest that the liver is involved. And of course, you want to monitor electrolytes and renal function too, especially in those really sick patients or if they're dehydrated.
So getting a full picture.
Exactly. A more complete picture of the patient's physiological state.
Of what's going on.
With the patient. Okay. What about imaging? Does that play a role in diagnosing enteric fever?
Imaging isn't routinely used to diagnose enteric fever.
Okay.
The diagnosis really relies on the clinical presentation and those microbiology tests that we talked about.
I see.
But imaging can be helpful in specific cases. So, for example, you might use an abdominal ultrasound to look for complications like hepatosplenomegaly or cholecystitis or intestinal perforation.
Yeah.
But again, this isn't part of the initial diagnostic workup.
So it's more of a targeted tool,
for specific scenarios, not a first-line test.
Exactly.
Okay, now let's move on to the real meat of the matter here.
Yeah.
Which is treatment. We know that. Starting the right antibiotics as soon as possible is crucial to manage enteric fever and to prevent those potentially really bad complications.
Absolutely.
So can you walk us through the general principles of treatment?
Sure. So when we're talking about treating enteric fever, I think the most important thing to remember is urgency.
Okay. The moment you even think, this could be enteric fever, we need to act fast.
Like immediately.
Yeah, like every hour counts.
Wow. Okay.
Because delaying treatment, that just increases the risk of those complications we talked about.
Right.
Which can lead to more severe disease.
Right.
And even death in some cases.
So it's not something to mess around with.
Not at all.
Okay, so what are we trying to do when we're treating a patient with enteric fever?
So we have two main goals. The first one is pretty straightforward. We want to make the patient feel better, get rid of those awful symptoms, the fever, the headache, the abdominal pain, all that.
Okay, symptom relief.
Exactly, symptom relief. But the second goal is even more important, and that's to prevent those serious complications like intestinal perforation, and chronic carriage.
Yeah, because those can have long-term consequences.
Exactly, long-term consequences for the patient and for public health.
So we're not just treating the individual. We're thinking about the bigger picture, too.
We're thinking about the community.
And thankfully, with effective treatment, we usually see the fever start to go down after about 3 to 5 days.
That's good to hear. So we can start to see some improvement relatively quickly.
Yeah, we usually do.
Okay, now, when it comes to choosing antibiotics, I know that often depends on how severe the illness is.
That's right.
So can you explain how the treatment approach differs for mild cases versus severe cases?
Sure. So if you have a patient with mild, uncomplicated enteric fever, oral antibiotics are usually enough. But if the patient has severe disease, especially if they have signs of systemic toxicity or complications, then they're going to need IV antibiotics.
That makes sense. You need to hit it harder.
You do. You need to be more aggressive with the treatment.
And how do we decide which antibiotic to start with?
Well, a critical factor is the local antimicrobial resistance patterns.
Okay, so knowing what's circulating.
Exactly. Knowing what's circulating in your area, especially the prevalence of fluoroquinolone resistance.
Right, because that can really guide our choices.
It really can. And that's where the WHO's AWARE guidelines are so helpful.
They're like our roadmap through this antibiotic jungle.
They really are. They give us a framework for making those decisions.
And they help us keep up with those ever-changing resistance patterns.
Exactly. Because resistance is a moving target.
Okay. So can you break down the specific recommendations based on the level of fluoroquinolone resistance?
Sure. So let's start with places where fluoroquinolone resistance is low.
Okay.
In those areas, ciprofloxacin is the first-line treatment for both mild and severe enteric fever.
Okay, so one size fits all.
Pretty much, yeah. And for adults, the usual dose is 500 milligrams orally every 12 hours.
So twice a day.
Twice a day. Now, for mild cases, you treat for 7 days, but for severe cases, you treat for 10 days.
Okay, so longer for severe cases.
Longer for severe cases, assuming, of course, that the patient is getting better and their fever has been gone for at least 2 days.
2 days.
48 hours, yeah. And for kids, you adjust the dose based on their weight, but the treatment duration stays the same.
So 7 days for mild, 10 days for severe.
That's it.
Okay, now, what if we're in a region where fluoroquinolone resistance is high?
Okay, well, that's a different story.
Yeah.
Then we need to switch gears.
Yeah.
For mild cases, a good option is azithromycin.
Okay.
And the usual regimen is a 1-gram loading dose on the first day, followed by 500 milligrams once a day for a total of 7 days.
So just one dose a day.
After that first day. Yeah, just 1 dose a day.
That's convenient.
It is. It makes it easier for patients to stick with the treatment.
Okay, and for those really sick patients with severe enteric fever in those high-resistance settings.
Yeah.
What do we do?
So in those cases, our go-to IV antibiotic is ceftriaxone.
Ceftriaxone.
Yep. And we give it intravenously at a dose of 2 grams once a day for 10 days.
Again, for 10 days.
Yes, but only if the patient is showing signs of improvement and their fever has been gone for at least 48 hours.
Okay, so we're always monitoring how they're responding.
Always. We're constantly reassessing.
Okay, now we've talked about the initial antibiotics. What about switching from IV to oral therapy?
Yeah, that's a good question. So the WHO AWARE guidelines say that you can switch to oral antibiotics once the patient shows clear signs of improvement.
Okay.
So once their fever is gone and their symptoms are better and they can tolerate taking pills.
It makes sense. You don't want to keep them on IV longer than they need to be.
You don't.
Yeah.
Nobody wants to stay in the hospital longer than they have to.
Right, exactly.
Yeah.
Now, I remember learning about some older antibiotics like ampicillin, chloramphenicol, trimethoprim, sulfamethoxazole.
Oh, yeah, those were the big guns back in the day. But resistance became a huge problem.
So are those completely gone, or do they still have a role to play?
Well, it's interesting because they've actually become more effective again in certain areas.
Really?
Yeah, it's true, particularly in parts of Asia where resistance patterns have shifted.
Wow, so they're making a comeback?
Kind of, yeah. But here's the thing. The WHO strongly recommends against using them as your first choice.
Why is that? If they're working again, why not use them?
Well, the worry is that if we start using them too much, we could see a resurgence of multi-drug resistant organisms.
Oh, so we're almost setting ourselves up for failure down the road.
Kind of, yeah. We've worked so hard to fight antibiotic resistance, and we don't want to undo all that progress.
That makes sense.
Yeah.
We need to be really strategic.
We do.
Yeah.
And save those older antibiotics for specific situations where we know for sure they'll work.
So susceptibility testing is key.
It's absolutely key.
Okay, now, I've heard some chatter about these extensively drug-resistant strains of Salmonella Typhi popping up.
Yeah, unfortunately, those are becoming more common.
What's going on with those? What makes them so challenging?
Well, they're resistant to a ton of different antibiotics.
Like the older ones we just talked about.
Yeah, even those.
That's okay.
And they're also resistant to fluoroquinolones and even some third-generation cephalosporins.
Wow, so we're running out of options.
It's getting harder to treat them, that's for sure.
And the fact that they're spreading globally through travel and migration.
Yeah.
That's really concerning.
It is. It has the potential to become a major public health crisis.
Okay, so how are we tackling these extensively drug-resistant strains? What are some promising treatment strategies?
Well, one thing that's showing some promise is combination therapy.
Okay, so hitting it with multiple drugs.
Exactly. Hitting it hard from different angles. And there's some evidence that combining ceftriaxone with azithromycin might be more effective against these resistant strains.
Interesting. So we're kind of entering this era where combination therapy might become the new normal.
I think that's a real possibility.
Okay, let's shift gears again and talk about how this bug actually causes disease.
Okay.
So as a reminder, we're dealing with Salmonella, enterica, serotypes, Typhi, and Paratyphi. And can you walk us through step by step how these pathogens get into our bodies and wreak havoc?
It all starts with ingestion. You eat some contaminated food or drink some contaminated water, or maybe you have direct contact with someone who's shedding the bacteria, and then those salmonella cells make their way into your gut.
So it's a fecal-oral route.
It is. And what's interesting is that humans are the only reservoir for these serotypes.
Right. It's really all about human behavior.
It is. Controlling human behavior is key to preventing transmission.
Okay, so we ingest these bacteria. Then what?
Well, their journey takes them to the small intestine, specifically to a part called the ileum.
The ileum?
Yep, and that's where they encounter these specialized epithelial cells called M cells.
M cells.
And these M cells, they're kind of like the gatekeepers of the gut immune system.
Gatekeepers.
Yeah, because they sample antigens from the gut and then present them to the immune cells.
So they're like the first line of defense.
In a way, yeah. But Salmonella is sneaky.
Okay.
It actually uses this system to its advantage.
So it's not getting caught. It's actually using it as a way in.
Exactly. It's like a Trojan horse. They hijack the M cells to get into the underlying lymphoid tissue called Peyer's patches.
Peyer's patches.
Yep. And that's where they start to multiply and establish themselves.
So they've breached the intestinal barrier.
They have their Well, now they come face to face with our macrophages. Those immune cells that are supposed to engulf and destroy pathogens.
Right, the big eaters.
Yeah, the big eaters. But Salmonella has another trick up its sleeve.
Okay.
It's evolved to survive and even thrive inside those macrophages.
What? No way.
Yeah, it's true. They actually manipulate the macrophages to prevent them from killing them.
So they're not only evading detection, they're actually using our own immune cells against us.
They are. They've turned our defenses into their hideout.
It's brilliant, but also terrifying.
It's definitely both.
Okay, so they're hitching a ride in these macrophages. They're spreading throughout the body. What happens then?
Well, as they travel through the bloodstream, they can reach different organs.
Which ones?
Like the liver, the spleen, the bone marrow, even the gallbladder.
So it's a systemic infection.
It is. It's not just confined to the gut.
And that's what leads to those classic symptoms.
Exactly. The high fever, the headache, the abdominal pain, and potentially those severe complications.
Okay. It's amazing how these tiny organisms can cause so much trouble.
I know, right? They're tiny but mighty.
Now let's zoom out and talk about the global epidemiology of enteric fever.
Okay.
What's the big picture here? Where is this disease most common?
So globally, enteric fever is still a big problem. While we've seen a decrease in cases and deaths since the 1990s, it's still a major concern, especially in places with limited access to clean water and sanitation.
So resource-limited settings.
Exactly. And the areas hit hardest are sub-Saharan Africa and South Asia.
And which countries have the highest numbers?
India, Pakistan, and Bangladesh consistently report the highest number of cases.
Okay.
Their incidence rates are over 500 cases per 100,000 population.
That's a lot.
It is. To put that in perspective, global estimates suggest there were around 14.3 million cases in 2017 alone.
Wow, that's a huge number.
It is. It's a reminder of how widespread this problem is.
And I imagine certain groups are more vulnerable than others.
Absolutely. Children under 15 are disproportionately affected.
I'd say kids are hit hard.
They are. They make up almost 60% of cases.
And that just highlights the need for better prevention measures.
It does. We need to protect these kids.
And what about outcomes? What's the prognosis for someone with enteric fever?
The good news is that with the right antibiotics, the case fatality rate is pretty low.
Okay.
It's around 1%.
1%.
Yeah. But we can't forget about those complications. They can be really serious.
Right, because even though the fatality rate is low, the morbidity can be high.
Exactly. It can have a major impact on the patient's quality of life.
So what determines whether someone develops complications?
Well, one of the biggest factors is how quickly we diagnose and treat the infection.
So early diagnosis.
Early diagnosis and early treatment are crucial.
Okay.
Because delays dramatically increase the risk of complications, especially intestinal perforation.
How long of a delay are we talking?
Studies have shown that people who have symptoms for more than 10 days before they get treatment are at a much higher risk.
10 days.
Yeah, so we need to act fast.
It's a race against time.
It really is.
Okay, so just to recap, the main players here are Salmonella, enterica, serotypes, Typhi, and Paratyphi. Now, are you ready for a little pop quiz?
Hit me with your best shot.
Okay, let's see how much you've learned. Here's your first question. Imagine a 25-year-old traveler just got back from Southeast Asia.
Okay.
They've had a high fever, headache, and abdominal discomfort for a week. What's the most appropriate initial diagnostic test?
Okay, so a traveler from Southeast Asia with fever, headache, and abdominal discomfort. That sounds suspicious.
It does.
I'd go with a blood culture.
That's right. Blood culture is the way to go.
You want to rule out enteric fever as quickly as possible.
Exactly. Okay, next question. We're in a region with high fluoroquinolone resistance, and we have a patient with severe enteric fever. What's our go-to IV antibiotic?
Okay, high fluoroquinolone resistance, severe enteric fever. I'd go with ceftriaxone.
You got it. Ceftriaxone is the right choice. All right, now for a trickier one. Which of the following is not a typical symptom of enteric fever?
Okay.
A prolonged fever. B, cough. C, headache. D, abdominal pain.
Okay, so prolonged fever, headache, abdominal pain. Those all sound like an enteric fever, but cough, that doesn't fit.
That's right. Cough is not a typical symptom of enteric fever. Good job. All right, next question. What's the key factor to consider when deciding whether to switch a patient from IV to oral antibiotics?
Oh, okay, that's all about clinical improvement.
Yes.
You want to see that their fever is gone, their symptoms are better, and they can handle taking pills.
Perfect. You're on a roll. Okay, last question. Which of the following statements about the Weil test is true?
Okay, bring it on.
A, it's the gold standard for diagnosing enteric fever. B, it detects antibodies against Salmonella. C, a positive result always means an active infection. Or D, it's highly sensitive and specific for acute infection.
Okay, so I know the Weil test has a lot of limitations, so A and D are definitely out.
That's right. Those are false.
And C also sounds too absolute. So I'm going to go with B. It detects antibodies against Salmonella.
You are correct. That is the true statement. The Weil test does detect antibodies, but it's not a reliable test for acute infection.
Right. It can be positive for other reasons.
Exactly. Well done. You aced the quiz.
Thanks. I tried.
I hope this deep dive has given you a solid understanding of enteric fever.
It has. I feel much more confident now.
That's what we like to hear. And remember, the world of microbes is always changing.
It is. It's a dynamic field.
So keep learning, keep asking questions, and stay curious.
Will do.
And we'll see you next time for another
Deep dive into the fascinating world of infectious diseases.
This is good.
I'll be there.
So globally, enteric fever is still a big problem. While we've seen a decrease in cases and deaths since the 1990s, it's still a major concern.
Okay.
Especially in places with limited access to clean water and sanitation.
So resource-limited settings.
Exactly. And the areas hit hardest are sub-Saharan Africa and South Asia.
And which countries have the highest numbers?
India, Pakistan, and Bangladesh consistently report the highest number of cases.
Okay.
Their incidence rates are over 500 cases per 100,000 population.
That's a lot. It is. To put that in perspective, global estimates suggest there were around 14.3 million cases in 2017 alone.
Wow, that's a huge number.
It is. It's a reminder of how widespread this problem is.
And I imagine certain groups are more vulnerable than others.
Absolutely. Children under 15 are disproportionately affected.
Okay, so kids are hit hard.
They are. They make up almost 60% of cases.
And that just highlights the need for better prevention measures.
It does. We need to protect these kids.
Now, what about outcomes? What's the prognosis for someone with enteric fever?
The good news is that with the right antibiotics, the case fatality rate is pretty low.
Okay.
It's around 1%.
1%.
Yeah. But we can't forget about those complications.
They can be really serious.
Right, because even though the fatality rate is low, the morbidity can be high.
Exactly. It can have a major impact on the patient's quality of life.
So what determines whether someone develops complications?
Well, one of the biggest factors is how quickly we diagnose and treat the infection.
Early diagnosis and early treatment are crucial because delays dramatically increase the risk of complications, especially intestinal perforation.
And how long of a delay are we talking?
Studies have shown that people who have symptoms for more than 10 days before they get treatment are at a much higher risk.
10 days.
Yeah, so we need to act fast.
It's a race against time.
It really is.
Okay, so just to recap, the main players here are Salmonella, enterica, serotypes, Typhi, and Paratyphi. Now, are you ready for a little pop quiz?
Hit me with your best shot.
Okay, let's see how much you've learned. Here's your first question. Imagine a 25-year-old traveler
Okay.
just got back from Southeast Asia. They've had a high fever, headache, and abdominal discomfort for a week.
Oh.
What's the most appropriate initial diagnostic test?
Okay, so a traveler from Southeast Asia with fever, headache, and abdominal discomfort. That sounds suspicious.
It does.
I'd go with the blood culture.
That's right. Blood culture is the way to go.
You want to rule out enteric fever as quickly as possible.
Exactly.
All right.
Okay, next question. We're in a region with high fluoroquinolone resistance, and we have a patient with severe enteric fever. What's our go-to IV antibiotic?
Okay, high fluoroquinolone resistance, severe enteric fever. I'd go with ceftriaxone.
You got it. Ceftriaxone is the right choice. All right, now for a trickier one. Which of the following is not a typical symptom of enteric fever? A, prolonged fever. B, cough. C, headache. D, abdominal pain.
Okay, so prolonged fever, headache, abdominal pain. Those all sound like enteric fever. But cough, that doesn't fit.
That's right. Cough is not a typical symptom of enteric fever.
Good job.
All right. Next question. What's the key factor to consider when deciding whether to switch a patient from IV to oral antibiotics?
Oh, okay. That's all about clinical improvement.
Yes.
You want to see that their fever is gone, their symptoms are better, and they can handle taking pills.
Perfect. You're on a rail. Okay, last question. Which of the following statements about the Weddell test is true?
Oh, wait, bring it on.
A, it's the gold standard for diagnosing enteric fever. B, it detects antibodies against Salmonella. C, a positive result always means an active infection. Or D, it's highly sensitive and specific for acute infection.
Okay, So I know the Weddell test has a lot of limitations.
So A and D are definitely out.
That's right. Those are false. And C also sounds too absolute.
So I'm going to go with B. It detects antibodies against Salmonella. You are correct. That is the true statement. The Weddell test does detect antibodies, but it's not a reliable test for acute infection.
Right. It can be positive for other reasons.
Exactly. Well done. You aced the quiz. So it sounds like you're well equipped to tackle enteric fever.
I think so. I've learned a lot today.
That's what we like to hear. And for our listeners out there, remember, enteric fever is a serious illness, but with the right knowledge and tools, we can effectively diagnose, treat, and prevent it. And as always, stay curious, stay informed, and keep those brains buzzing with all things microbiology. We'll see you next time for another deep dive into the fascinating world of microbes.